We are talking about the stent pharmacology, and you have got for a stent you have got a base stent platform metal which is carrying a drug in a polymer for a drug eluting stents. And now what happens, the platform gives the scaffold metal for platform, the drug gets eluted over a period of time, and the polymer, depending on the kind of polymer, either it stays or gets degraded. So what are the desirable features of an ideal stent? It should be biocompatible, obviously. It should not produce inflammation and reaction. It should be visible, radio opacity should be there, otherwise it will be difficult for you to deploy it. And in tortuous vessels, it should be flexible, easy to deliver, and there should be strong radial force, and it should not excite inflammation, neointimal hyperplasia, and of course it should not be thrombogenic. So what are the concepts here? Radial strength, it is the ability of the stent to provide vessel wall support to prevent recoil. When you dilate it, vessel tends to recoil, so you want to, that is the basic purpose of a stent. And there should be enough scaffolding so that the erythematous tissue or the tissue does not prolapse. It should conform to the vessel both in static and dynamically as it moves and contracts, and we should be able to deliver it through the tortuous and calcified vessels. So basic stent platforms are stainless steel, cobalt chromium, platinum chromium and ethanol. These are commonly used. The stainless steel platforms were originally used and they have poor radio opacity, whereas cobalt chromium and platinum chrome, they are more radio opaque and have better radial strength, and platinum chromium gives much more radial strength. Any other than those taking stainless steel can allow thinner struts because they are more dense metals. So with thinner struts you can achieve the greater radial strength. So why the strut thickness is important? The advantages of larger thicker struts is it is easily visible and gives better radial strength, but the disadvantages are it gives more vessel injury and more intimal hyperplasia, higher in-stent restenosis. That's why for a period of time the thick struts have come down to thin struts. If you see, the angiographic and clinical restenosis rates are much higher with thicker when the thick struts are there. These are in the earlier data when we are using bare metals with different strut thickness. So what are the different kinds of stent designs? There can be coil stents. They are initial designs. The original stents that we are using, the Victor stent and Gian Turco stents, they are coil stents. They didn't have good radial support and the tissue tends to prolapse more. Later came starting with Palmer short stent, the slotted tubular stents are there, which are laser cut to give the stent module. And the modular stents are, as you can see in the Medtronic, there is a sinusoidal waves which are connected together. These are all different stents. You can see the tubular slotted stents and wire stents. And another consideration in the stent is whether it is an open cell design or a closed cell design. The open cell design is all the struts are not connected throughout the circumference. If the stent struts are connected to each other, it gives more strength to the radial force to the stent, but the cells will not be accessible, it will be crowded. If you have got a open cells, that means all the struts are not connected to each other in the periphery along the circumference. It will have better flexibility and deliverability, and side branch access will be there, but the radial strength will decrease and flexibility will decrease. So you have to have a combination of these two designs. Another problem with open and closed cells is, in the open cells, as it in a tortuous vessel in a bend, on the convex surface, the upper surface, there will be less drug delivery because there is not much of metal there with polymer, with the drug, whereas on the lower surface the drug will be more concentrated. So there are both advantages and disadvantages. If the open cell design is there, it will have less radial strength, plaque tends to prolapse, metal artery ratio is less, which is good, but it also has increased conformability and increased side branch access, but the main thing is radial strength will be less. Whereas in the closed cell design, radial strength will be more, plaque prolapse will be less, metal artery ratio will be more, conformability will be less, and side branches access will be less. So what are the other features? The stent surface finish is important. If you actually see the stent manufacturing, the electro polishing will be done. If you can look with the scanning electron microscope, small pits will be there. These are the surface area is rough, that can be more thrombogenic because the platelets can go and sit there. So, surface finish is one of the important aspects which is not often talked about, and also the strut shape. The round struts are better because the square struts can produce thrombolysis, the lysis of the cells. And stent length used to be important factor. With the bare metal stents, we all know we want to always do a focal stenting because that will produce more of neointimal hyperplasia, restenosis. But the length of the stent does not appear to be a factor when you are using a drug-eluting stent. It is another common notion. Of course, we do not have to discuss because bare metal stents are hardly used now, but for any given degree of diameter, drug-eluting stents have lower restenosis rates compared to the bare metal stents. Now, longitudinal stent deformation is important aspect which occurs with most of the stents, not necessarily with the Promos stents. And the Promos element, of course, is one of the important things because it is the character of the chromium platinum metal alloy that it tends to have longitudinal deformity more. But the same deformities can also occur if one uses multiple stents or guide liner or post dilatation at very high pressure. So, one has to keep it in mind that you do not use any of these, you try to avoid any of these so that you get a better long term result. And another thing is minimal balloon overhang should be there. So, your stent selection should include that. And now then comes apart from the metal platform, we have the polymers. Why do you need polymers? Because you want to elute the drug from the stent into the vessel wall, and the stent metal surface cannot hold adequate quantities of the surface. The drug cannot be coated adequately onto the stent surface. So, polymers act as a reservoir which are coated on the stent surface and they slowly elute the drug. And what should be the characters of the polymers? They should be biocompatible and do not interact with the active drug. Appropriate drug-eluting kinetics should be there and behave biologically inert and be mechanically stable at long term in the dynamics of the coronary circulation. So, the polymers can be inert and active. The passive ones are active ones. The passive ones, they tried initially with heparin, gold, carbon, silicon because they do not interact and they do not produce any inflammation. But actually, the gold coated stent came sometime back, they produce higher rates of restenosis. So, they are not much in use. We use the active coating polymers. The polymer can itself be, though it is biocompatible, it may be just bio-inert or biocompatible or biodegradable. The Cypher stent came with inert polymer, Cypher stent, a 3-layer polymer, and its elution kinetics were 60 days. But the whole problem started there, and as the polymer continued to remain there, it produced lot of reactions, inflammation, thrombogenesis, and very late stent thrombosis was one of the problems with the initial polymers used. So, this has been changed to biocompatible polymers, so which are more stable compared to the polymers used in the Cypher stent and Taxus stent. Later, we also have biodegradable polymers, which as the drug is eluted, the polymer also gets degraded, like poly-DL lactic acid. Lactic acid is like milk. You can just remember milk and sucrose are one of these polymers of the carbohydrates. They just dissolve over a period of time, they get metabolized, and it will not be there in lying on the stent. These are the biodegradable polymers. One of the stents use biomatrix, you can see here, various kinds of polymers are used, and according to the compound used, these polymers will be biodegradable within different periods of time. So, all these stents now being used, biomatrix, Nobori, Synergy, Unimaster, Ultimaster, all these are biomime, they contain biodegradable stents. And finally, the drugs, initially sirolimus and paclitaxel are used, and they work on the various phases of the cell cycle, and sirolimus and paclitaxel are now replaced with more lipophilic drugs, which are everolimus, jetrolimus and violimus. Because of the lipophilicity, they tend to be on the abdominal surface and they penetrate better into the vessel wall. Over a period of years, decades, rather 2 decades now, a lot of changes occurred both in all the 3 parameters, drugs, carriers as well as the stent platform. Now, stent platform composition, as we saw, changed from stainless steel to cobalt chromium, now platinum chromium. The drug carriers have increased biocompatible polymers, then biodegradable polymers, then some of the newer stents don't even have any polymer. The drugs have changed from sirolimus, paclitaxel to everolimus now. If you see the progression here, you can see over a period of years, as I mentioned, the strut thickness has come down from 140 microns to 74 microns in the Synergy stent now. And similarly, if you can see the various components here, the platform strut thickness has changed, the coating distribution, the coating thickness of the polymer has changed over a period of years, and also various drugs are used, and the coating distribution is sometimes circumferential and sometimes on the abluminal, that is delivering the drug only on the abluminal surface onto the vessel wall, not onto the lumen. So based on this, the first generation stents can be called, we call Cypher and Taxus the first generation stents. Endeavour, Giants, Promus, Resolute, Integrity are second generation stents, and Promus Element, Promus Premier, Taxus can be called third, and bioabsorbable devices, bioresorbable devices and polymer free devices are the fourth generation. These are some of the classifications. So as I mentioned, the Cypher and Taxus were the first stents to come. They had bigger strut thickness and different polymers. They produced lot of reactions. Though they decreased the target vessel revascularization, they are associated with late and very late stent thrombosis. It is almost 0.2 to 0.5% per year, and delayed yield healing was there. So to circumvent this, the changes have occurred. The Endeavour stent is one of them, which uses the PC polymer and uses the jetrolimus drug. And the other second generation stents are Zynes and Promus, which used cobalt chromium. You can see the metal composition on the right side, and they use everolimus stent, everolimus as the drug, and they are better polymers, more compatible. With the trials with the jetrolimus eluting stents, you can see they are definitely superior to the bare metal stents, but they are inferior to the sirolimus eluting stents and on par with the paclitaxel stents. These are some of the earlier generation jetrolimus stents, but later the performance has improved. The clinical trials of everolimus eluting stents, Zynes and Promus, they are definitely superior to the paclitaxel eluting stents, and 1 year event rates, they are not much between the sirolimus eluting and everolimus eluting stents, and they are probably superior, somewhat superior to the jetrolimus eluting stents. The polymer free stents are also being used, and here there is no polymer. The microporous structure will be there on the abluminal surface and the metal platform, which will release the drugs for a period of time. One of the commonly used stents is the Yukon stent and biofreedom stent from the biosensors. They are commonly used, and the long term results appear to be as good as the biocompatible polymer stents. The partially bioresorbable stents, where the polymer is resorbed over a period of time. This you can see as in the Synergy stent. The drug and polymer both get eluted over 90 to 120 days. So at the end of 3 months, neither the polymer nor the drug is there on this one by the time the neointimal endothelialization should take place. And 1 year event rates compared to the Promus element and Synergy, there is no significant difference. However, the late in this Synergy trial, evolved trial, the late thrombosis is also not different, but the consideration is that the bioresorbable stents will have better late stent thrombosis rates. Here you can see when the patients are followed for 2 to 5 years with the bioresorbable stents, there is significant decrease in the late stent thrombosis. The another technology is the abluminal coating, which will have better vessel wall penetration of the drugs, and they yield good results. And these are different kinds of bioresorbable stents, of which we are all familiar with the B.K.S, which was marketed, but unfortunately did not succeed. The idea concept, all of you know, is a biodegradable over a period of time, and to give initial scaffolding with these polymers, the strut thickness has to be very big. That is the problem with the deliverability of these stents, and the consideration was it will long term resolution reabsorption of the platform itself will decrease the neoatherosclerosis, stent fracture and stent thrombosis. However, we know that this is not the case, and actually stent thrombosis was more in these patients. The other considerations are the magnesium and metallic zinc are considered, but magnesium kinetics will lead to more toxicity, and zinc, they are all in experimental stages. We don't have them as on today. Now, the final 2 slides, we know that there are different imported stents. They are imported in the sense Zyme, all these multinationals, so we are all familiar with these stents. Now look at the platform, they use the same stainless steel, cobalt, chromium, platinum, and the thickness varies from anywhere from 81 to 112 microns. And except biomatrix and synergy, most of the polymers are just biodegradable, and of course they use different drugs, zetrolimus, everolimus and sirolimus, we all know that. Now what do you think? Surprisingly, I was surprised to find most of the stents which are manufactured here, Abluminous, Biomime, the strut thickness is much less, and all of them have biodegradable polymers. So if you have to go by theoretical considerations, the stents that we have in house, Abluminous, Biomime and all these stents, they have better physical characters in terms of the strut thickness as well as the polymers used. But unfortunately, we don't have good data about them. I hope I have covered the topic which was assigned to me. Thank you very much.